Good morning, everyone. Today we'll be starting our lecture series on psychiatry. So today, our first topic for today will be approach to depressive disorder, taken by Dr. Abigail Ruth Gojer. She's an assistant professor in the Department of Psychiatry 1. And topic of interest is on personality disorder. And she has completed her DPM and MD from CMC-Vellore, currently working as a faculty consultant in the Department of Psychiatry 1. And today's topic is approach to depressive disorder. Over to you, ma'am.
Okay, thanks, Nitin. Sure. So I'll start with today's class. Today we'll be having a brief and a rather pragmatic look at a phenomenon that is frequently encountered, not just in the community, but in clinical practice as well, be it the general medical or the specialized psychiatric setting. Now, the term depression is often used very commonly, but the thing is, it could mean different things when it comes to person, and also when it's taken in various contexts. Now, what do I exactly mean by this? When it's used in multiple ways, it can be confusing because it can refer to something as simple as a frame of mind or a state of mood. Now, this could be indicated by feelings ranging from sadness to anxiety to even despair, feeling of emptiness, hopelessness, or sometimes having no feelings at all. Now, this low mood, or what we generally call as dysphoric mood, it could be normal, or it could be just an adaptive response to either loss or disappointment, or even failure, which could be real or perceived. On the other hand, this low mood can also be a symptom of a psychopathological syndrome or another medical disorder. When you talk about depression as being part of a syndrome, and by this I mean a constellation of signs and symptoms of which low or depressed mood is just one, it could either be in the context of a biological or an endogenous depression, or it could be part of a dysthymia, and we'll be discussing this in further slides. On the other side of the spectrum, depression can be part of a mental disorder that is a distinct clinical condition. So you frequently see depression occurring in severe mental disorders as well, be it unipolar depression as part of bipolar affective disorder, as part of schizophrenia, or even substance or medication-induced depressive disorder. So what is a big deal? Why do we need to know about depression? So the WHO has actually identified depression as being the 11th greatest cause of disability as well as mortality in the world among a vast range of illnesses of 291 diseases or even causes of injury. And we know that all the symptoms of depression are quite prevalent among primary care patients. Very few people discuss these symptoms directly with their point of first contact or with their primary health clinicians. Now, most often these people won't come up with low mood or feeling dull or feeling hopeless. They would rather present with a vast range of somatic symptoms. And this would contribute to making the detection of depression much more difficult. Now, people omit information about depressive symptoms unless they're directly asked about their mood. And this could be for a variety of reasons. It could be because of fear of stigmatization. It could be because of an undue belief that somehow depression is a personal flaw or a failure. They could be having concerns about breakage of confidentiality, and they could be having practical concerns about being prescribed drugs which they're not ready for, or even a referral to a psychiatric specialist. We know that untreated depression is associated with decrease in the quality of life, with increased risk of mortality, of which the risk of suicide is just one. It could lead to poorer outcomes, especially when it co-occurs with chronic medical conditions. What is to be remembered is the consequences or the effects of depression extends far beyond the individual patient. It has a substantial impact on their family life, not just their spouses, but on their children as well. And it can have a significant bearing at the workplace as well. And the rather startling, or to be quite frank, the alarming fact is that almost half of patients who can be diagnosed with depression remain undetected. So when you look at the epidemiology, we know that depression is highly prevalent throughout the world, and this prevalence appears to be increasing over the past few years. It could range from as low to 3 to as high as 17 to 20%. And in India, the prevalence based in the recent article in the Lancet, which took into consideration accounts of mental disorders from 2000 to 2017, shows that the prevalence in India is around 3.3%. Now, the reasons for lower prevalence in some countries, especially in countries like ours, could be due to factors which are both cultural and genetic in nature. It could be because of sample selection biases. It could be due to problems with the cross-cultural portability of the diagnostic criteria. Depression is difficult to detect in cultures where patients are more likely to present with somatic rather than expression of their emotional symptoms. Now, what could be the barriers to appropriate identification and effective management? We all know it could be due to a lack of awareness, and in a setting such as ours, there could be scarcity of time or scarcity of available resources. When I speak about disguised presentations, rather than the most common encountered somatic presentation, it could also be a presentation not just with low mood. People can present with more of irritability, with concentration difficulties. It can be presentation with increased substance use or acting out or behavioral problems in the form of promiscuity. In the child and adolescent population, it could present with truancy or school refusal. In the geriatric population, it could be presentation with confusion or a gradual cognitive decline, or even a general reduction in overall functioning. Things which we can bear in mind and do something about are our own attitudes and addressing deficits in medical training. Now, this is not a comprehensive list of risk factors. Remember that risk factors would include not just genetic or environmental ones, they could also involve medical as well as social influences. Another way of looking at risk factors would be categorizing them into modifiable versus unmodifiable ones. It is to be remembered that although being aware of risk factors can be clinically significant and clinically helpful, it is actually not sufficient to guide clinical practice or the decision to screen for depression. Now, the presentation can either be in terms of mood, which I've discussed briefly before. It can be in the form of neurovegetative or biological symptoms, including anergia, differences in patterns of sleep, appetite, and as a consequence of appetite, weight fluctuations. One point to remember is reduction in libido can either be a cause of depression or also can be a consequence of the same. And somatic complaints is the most frequent way of presentation that we generally see in our clinical practice. The population in which somatic symptoms predominate would also include women who are pregnant, older individuals, and patients having lower incomes, as well as with coexisting medical comorbidities. Now, for the diagnosis of depression, quite a few of the classificatory system go by a checklist. So there's a symptom count, and certain symptoms are given more weightage than the others. And there's a checklist with a certain cutoff by which you can conclude that this person would qualify for an episode of depression. So when you look at the ICD-10 criteria, the three core symptoms would obviously be mood, which is low or depressive. There can be anhedonia, which is defined as a loss of interest in pleasurable activities, activities which were previously held to be pleasurable. And there can also be a reduction in energy and fatigue. So these are the core three symptoms. along with a set of certain minor symptoms which involve high mental functions, self-esteem or self-confidence, undue feelings of being guilty or being unworthy, having very pessimistic outlook, thoughts of self-harm, and disturbed biological functions. Most of us would have experienced some of these symptoms through our lives, and we're probably going to experience that in the future as well. So when does this qualify for depression is if these symptoms are present for most of the day for a minimum period of at least 2 weeks. Now, the severity of depression can also be graded based on the major and the minor criteria, with severe depression requiring all 3 of the core symptoms and at least 4 on 8 of the minor ones. It can also be specified by the presence or the absence of somatic syndrome, or with the presence of or the absence of psychosis. Now, when you talk about severe depression with the presence of psychotic symptoms, the psychosis should always match the mood. And the term for this is it should be mood congruent. So if a depressed person is having hallucinations or delusions, it is mostly in the theme of nihilism or guilt or being unworthy and deserving to die. Now, the DSM-5 gives another list of similar symptoms with different cutoffs. So sitting in an OPD, in a busy OPD or in a general ward, it's not going to be possible for you to list out all the symptoms and then try to categorize them to see whether clinical depression can be diagnosed or not. So the 12-item version of the general health questionnaire again gives a list of 12 symptoms. There's no need to be overwhelmed by this, even though it gives a score on a Likert scale with a score of 3 on the screening instrument, requiring further evaluation or referral to a psychiatrist. What you need to remember is take just 2 questions. So in the past 1 month, has the patient been feeling low, feeling down, or feeling hopeless? And similarly, in the past 1 month, has there been the presence of anhedonia? If the person replies yes to either of these 2 questions, that would warrant further evaluation for a depressive disorder. Now, untreated depression spontaneously remits, with half of them undergoing remission or achieving remission within a period of 1 year, and almost three-fourths of them after a period of 2 years. However, it is important to remember that subsyndromal symptoms can persist even after the full criteria for a depressive disorder are no longer met. And the most common symptoms to persist over time, even after remission is achieved, would be insomnia. This is closely followed by the mood which is low, and then by a decrease in concentration. The persistence of such subsyndromal symptoms would also heighten the risk for recurrence of the full depressive syndrome. Studies have shown that individuals who have suffered from at least 1 episode of depression frequently have recurrences. And among patients with a history of depression, at least 72% of them report having more than 1 episode. Depression generally occurs in the early part of life, in the late 20s or the early 30s. And the earlier the age of onset is seen to be associated with poorer bio, psycho, as well as social outcomes. Now, this slide is just to get a clearer understanding of what is not depression. Now, differential diagnosis need to be distinguished in order to prevent inappropriate treatment. When it comes to general medical conditions, it could run the gamut from anemia to B12 deficiencies, to endocrine dysfunction, to multiple sclerosis, to strokes, to autoimmune disorders. Depression can occur as a direct consequence of the illness itself, or it could be as part of the distress and the impairment of functioning associated with these. Depressive disorders due to another medical condition is not diagnosed if the mood change is seen to clearly precede the onset of the medical condition, or if it occurs solely during an episode of delirium. Now, when I mention drugs, it's not just recreational drugs. Depression can occur either in the phase of intoxication or withdrawal. Even common drugs that we use for hypertension or diabetes, propranolol has been shown to cause depressive symptoms in a vast number of patients. The second point that I would like to mention is sadness. Now, sadness or even irritability, just by itself, in the absence of other symptoms, does not warrant the diagnosis of an episode of depression. Sadness almost every day for a period of at least 2 weeks, along with the other symptoms and associated distress and psychosocial impairment, is required for the diagnosis of depression. Please remember that sadness could be normal. It could be an adaptive part of the general human condition, particularly in response to loss, disappointment, or situations which are challenging in life. So as an extension of that, when you look at stressful life situations or adjustment disorders, this is in the context of identifiable psychosocial stressors. It need not always necessarily be a single major event. We know that mostly in our lives, it's a series of multiple minor stressors, which can be recurrent or continuous, which would cause us to have fluctuations in our mood. And mostly these fall under the domains of interpersonal conflicts. It could be academic failures. It could be even painful, if not serious illnesses, as well as work-related pressures. Similarly, when you come to grief, how would you distinguish grief from a depressive disorder? In depression, the sadness or the low mood is pervasive, whereas in grief, the sadness is clearly related to bereavement or mourning of the individual who is being missed. So the guilt and grief would also be related to probably caregiver self-blame, whether it's warranted or not. Other associated symptoms would include a yearning for the deceased individual, along with repetitive or intrusive thoughts, or experiencing intense emotions which are triggered by reminders of the loss, as well as efforts to avoid these reminders. When it comes to bipolar disorder, um, actually bipolar disorder is frequently underdiagnosed if the presenting complaint of a person is a depressive symptom. And it is crucial to ask for a past history of either mania or hypomania, because the treatment would be vastly changed by the change in the diagnosis. Just a brief note on borderline personality disorder. BPD and depression have common symptoms in the form of dysphoria or recurrent suicidal ideations. It is to be remembered that in personality disorders, the mood states fluctuate within a single day, and other significant symptoms like disturbances in identity, efforts to avoid abandonment because of a fear of a same, as well as chronic feelings of emptiness are frequently seen. Now, a broad look at approach to management would be trying to figure out whether this is reactive in response to stress or whether it's endogenous or biological in nature. And also depending on the course, whether it's unipolar, that is recurrent episodes of depression, versus a bipolar where there's at least one episode of mania or hypomania involved. When you look at adjustment disorders or dysthymia, these are seen as reaction to stress. In adjustment disorders, there is an emotional or a behavioral reaction to a stressful life event or a significant change in a person's life. The presentation could be in terms of depression, in terms of anxiety, a combination of depression and anxiety. There could be disturbances of emotions or even conduct, and by conduct, I mean behavior. It is to be remembered that these symptoms resolve once the stressor or the consequences of the stressor have come to an end. Dysthymia refers to a mild but a chronic form of depression. It's also known as persistent depressive disorders, and it is diagnosed when symptoms are experienced for at least a period of 2 years. When it comes to stress reactions, the treatment would be predominantly psychotherapeutic interventions, with medications playing a limited role. So when I spoke about endogenous or biological depression, these are the symptoms or the melancholic symptoms which need to be borne in mind. So the major criteria would be a lack or complete absence of emotional reactivity to stimuli which are usually held to be pleasurable by the individual, and they can also be anhedonia. And the minor ones are mostly in relation to the biological symptoms. So there can be changes in psychomotor activity, either in the form of retardation or excitement, weight loss quantified by at least 5% over the past 1 month. The sleep disruption in biological depression is always terminal insomnia as compared to global insomnia or delayed onset of sleep when it comes to stress-related mood symptoms. In biological depression, mood or the low mood is worst while waking up in the morning, and it gradually is seen to improve over the course of the day. Whereas mostly the opposite happens when you're having just an adjustment disorder, because you're able to function to a certain extent and you're not able to think of whatever is distressing you or troubling you. At the end of the day, when there's nothing to divert your attention, that is when you start having a lot of anxiety or depressive cognitions when it comes to adjustment disorders. In melancholic symptoms, there can also be undue guilt and a certain black sort of a mood, which is termed as despondency or despair. Now, I'll briefly be discussing of practical suggestions which will be useful to you. Now, the 10-step approach is based on the reattribution model. Now, this has been developed in collaboration with physicians over many years, and this has been modified over time to incorporate certain principles which are both psychiatric as well as physician related. Now, the steps in the 10-step protocol would be obviously the first one, to identify and recognize the underlying presentation. Again, people may present with symptoms other than low mood, and the context often include psychosocial problems. And sometimes these concerns do not respond to hasty medical reassurance or negative diagnostic tests. What is required is acknowledgement of distress. The failure to do this could be interpreted by patients as an indication that the doctor has not understood the problem or that he or she does not believe that the symptoms are genuine. Another important factor is just acknowledging that the patient's distress is real, leaving beside the underlying diagnosis, could bring about an attitude of empathy, and it could contribute to the establishment of good rapport as well as the formation of a therapeutic alliance. And these are crucial in facilitating improvement. It's also important to see what the person's and the caregiver's perspective of the symptoms are. So it is effective if reassurance is actually based on what the person's actual concerns are, and asking what they think or fear is wrong with them would be useful in addressing these concerns. Now, the beliefs of the patients may not actually match with what you think the problem is. However, their beliefs need to be discussed before you present your alternative biomedical model. Outright rejection of the person's beliefs early in the consultation, or even a failure to acknowledge the same or elicit the same, can be disastrous. Eliciting these explanations would actually help you in following up with a focused examination, relevant investigations, and then providing specific reassurance. In depression, investigations are not for the diagnosis, it's to rule out other contributory causes. And some important points which should not be missed out in history would include understanding the current set of symptoms, going into detail about past episodes, identifying exacerbating and relieving factors, including life context, determining the impact on overall functioning, checking for past mania or hypomania, addressing comorbidities, as well as to assess the possibility of self-harm or suicide. Now, a misconception is if we ask about suicide, we are putting the thought of suicide in a person's head who had not thought about it before. Actually, the opposite is quite true. Some people who are struggling with ending their lives may not have shared this with anybody. And even though the information may not come out voluntarily, the fact that somebody has asked them about it would provide a sense of relief, and adequate steps can be taken to address this. Once the evaluation is complete, the next step would be talking to the patient about the symptoms, the syndrome, and the management principles. So the emphasis should be on reassuring the patient about the absence of any serious physical illness while acknowledging the reality and the distress which are caused by these symptoms. It's also important to discuss about the mind-body relationship. So simple explanations of how anxiety, stress can cause physical symptoms, can cause low mood, or how even depression would lower the threshold for pain are quite useful. Once this is done, only then would we go into medications. Now, the choice of antidepressant medication is actually based on a very simple factor. It's based on whether the patient requires a sedative agent, that is if he's having insomnia or if he's sleeping well. Now, sedative antidepressants should be used in patients who are having insomnia, and the most common drugs that we use in such a situation would include the TCAs and mirtazapine. If we use SSRIs in patients with insomnia, we would actually be pushing them into the use of over-the-counter benzodiazepines, and the possibility of dependence on the same is quite high in such individuals. Now, this is a whole list of the classes of antidepressants. There's no need to be aware of all of them and to go into great detail of all of them. What is to be remembered is that all of them are quite equally efficacious, and all of them have a little bit of a treatment lag. But if people have been suffering from insomnia, just the fact that a good night's sleep is achieved can go a long way in helping in reduction of the other symptoms that they're experiencing. Now, the lack of clear superiority among antidepressive agents, because of this, the selection of a drug is based on other factors, which would include the safety as well as the side effect profile. It could be based in the context of the comorbid illnesses and contraindications for certain drugs. It can be the ease of the use. By that, I mean the frequency of administration and dosing. It could be based on patient preference or even patient expectations. It could be based on cost factors. And it is to be remembered that sometimes looking into past response during prior episodes, not just for the patient, but as well as in the first degree relatives, will also help us in choosing a drug. Because of the cardiovascular side effects or the bearing on cardiovascular bearing of tricyclic antidepressants, the potential for a fatality of overdose by TCAs is quite high as compared to SSRIs. So if you feel that a patient is prone or is at a risk of committing suicide, one thing that can be done is prescribe a TCA, but for shorter durations, and make sure that the medications are also supervised and suicidal assessment, risk assessment is done at every point of contact, or to go to a safer route and prescribe an SSRI with some concomitant medications if inpatient admission is not a choice at that point of time. So briefly speaking of the common drugs that we use over here, the sedative ones would include the TCAs. The starting dose would be 25 milligrams and not 10 milligrams. 10 milligrams actually does not do much for the patient. You can achieve a therapeutic dose of 50 to 100 and if required even 150 milligrams. And the side effects of TCAs are mostly based on the anticholinergic side effects. Mirtazapine, you could start off at 7.5 or 3.75 if sedation is a huge complication, with a therapeutic dose ranging from 15 to 30 milligrams. The SSRIs are known to be associated with GI side effects as well as headache. Now, the duration of treatment would be at least 3 to 6 months, followed by an attempt of tapering. But in some cases, these medications can be safely used for many years on the occasion of a relapse of symptoms when you're trying to withdraw the drugs or taper the drugs. Once the medication has been prescribed based on the patient's profile, we next need to discuss about the role of stress, not just as a cause of these symptoms, but also as a sequelae or consequence of the same. Some common presentations in the OPD, men, especially in the younger age group, who would present with a lot of non-specific somatic symptoms, could be having some underlying low mood because of sexual misconceptions or even dysfunction. Similarly, women who are having long-standing marital discord or spousal abuse, or who want to avoid pregnancy, but where contraception is not practiced, can also present with a similar picture. It is important to discuss about the link between stress and low mood or even somatic symptoms, because then the burden of responsibility is shifted onto the patient, and would also take away the need for doctor shopping, which they often resort to. Even if the patient denies the presence of stress, just a mention of the possible mechanisms which are commonly seen will get them thinking about the same. Once stress is discussed, then we talk about how to deal with stress. It could include general coping measures like relaxation, meditation, just regular physical activity or exercise, yoga, involvement in activities which give comfort and a source of strength like religion, hobbies, leisure, talking to people. All these have been seen to improve coping and are useful for those who are undergoing a stressful situation. And remember that these strategies are useful for everyone, not just for those who are not able to cope with the stress of living. While some forms of stress or social adversity can be modified or can be changed, more often than not, stressful situations require a change in our attitude, our philosophy, and lifestyle. So people with specific problems which can be altered can be helped with problem solving. So some things which can be done in the medicine OPD would be as simple as just allowing the patient to talk, to normalize or universalize the feelings that they're experiencing, providing non-judgmental support, encouraging activities, making sure that they're behaviorally activated, to talk about cognitive reframing strategies. Also practical suggestions like postponement of important decisions when you're having mood fluctuations, conveyance of hope. Specific psychotherapeutic interventions like cognitive behavioral therapy, psychodynamic therapy, supportive or interpersonal social rhythm therapy will be done by us when the patient is referred to the psychiatrist or the mental health practitioner. It's also important to negotiate a treatment plan. And in this phase, the responsibility for improvement is gently but firmly transferred onto the patient. Alongside, there's the offer of continuous psychological support, and compliance with the treatment regimen is discussed in this phase, as the patient would participate in stress reduction strategies as well as trying to improve overall coping strategies. And finally, regular review of progress is necessary. These appointments should be scheduled and not on a PRN basis. And on each review, a brief review of symptoms, improvements, or new problems, or even a brief focused physical examination, if indicated, has to be performed. Now, when do patients with mood symptoms require to be referred? This would be based on the clinician's overall level of expertise or confidence in self. It could be based on the availability of resources of referral, and more often than not, it could be based on patient as well as caregiver preferences. Certain situations when referral is a must is when the diagnosis of depression is rather ambiguous, when there's a risk of harm to self or to others, either overtly in nature or because of a more passive way in decline of care for self, neglect of self, lack of eating. That is when referral definitely has to be done. When the depression is severe in nature or associated with psychotic or catatonic symptoms, and depression that occurs in the context of severe mental disorders, either schizophrenia, schizoaffective, or bipolar disorders. So briefly, I'll just go through a couple of case scenarios. So when you look at the first one, there are quite a few risk factors involved. So she's female, she's in her mid-20s, she's postpartum. In India, the birth of a girl child also has significant connotations. Arranged marriage into a joint family setting, economic stressors, interpersonal issues with the mother-in-law, lack of privacy in the marital dyad, being criticized, and the somatic symptoms not being taken seriously. It would all look like an adjustment. But on further questioning, there are death wishes. There are feelings and ideas of worthlessness. There is a little bit of neglect of the baby. There are biological symptoms which are seen. So this would definitely indicate the need for medication as well as psychotherapeutic interventions, because the risk is not just to the patient, there's a risk of harm to the child as well. In the second scenario, again, there are a lot of psychosocial factors. There's loneliness, there's sensory deprivation, there's being social isolation, immobility. There is a little bit of decline in appetite and social withdrawal. But on the other hand, insight is fairly preserved. There's no psychotic symptoms, there are no melancholic symptoms. And even though medications may be indicated for a short period of time, coping or other forms of psychotherapy would be useful in such an individual. In the third case, so this is how a severe depressive episode with psychosis could possibly present. So there are depressive symptoms. There's anhedonia, there's social withdrawal, there's lack of sleep, lack of appetite, weight loss, neglect. And in addition to this, there are delusions and hallucinations of guilt, of nihilism, of probable command hallucinations. This is a psychiatric emergency. Admission is indicated. High dose of antidepressant medications and possibly even ECT is indicated in such a case. So the take-home points would be that depressive symptoms are very common, but it can have a lot of connotations in various contexts. The screening for depression, if there's a suspicion of the same, is mainly based on two questions, based on low mood for most of the time over the past 1 month, as well as anhedonia. The approach would be trying to establish whether it's biological in nature or whether it's reactive in nature, because then the interventions would be predominantly medical versus non-pharmacological respectively. So that is it from my side. Thank you.
Thank you, ma'am, for that elaborative approach on depressive disorder. Now, if you have any doubts, please type in your questions in the chat box. We'll have another 2 to 3 minutes for the doubts. Ma'am, one question, what are the indications of ECT in depression?
ECT is when the depression is severe, when there are catatonic symptoms, when there are psychotic symptoms, when the risk of suicide or harm to others is quite high. That is when ECT is indicated. in the postpartum period, when sometimes drugs may not be safely given because of lots of medical comorbidities or drug interactions. These are situations when ECT could be preferred rather than waiting for the antidepressants to take time.
Okay. Are there any more doubts? If there are no more doubts, we'll wind up the session, and this lecture will be available in our YouTube channel in a week's time. And next lecture on psychiatry will be on the topic anxiety by Dr. Abhinav next Friday on 16th. And again, ma'am, thank you on behalf of medicine department for giving your time, ma'am, for that on that elaborative approach. Thank you, ma'am.
No problem. Thank you very much.